Good morning, everyone, and welcome to the final segment of the Virtual Rheumatology Learning Collaborative. We're going to start off this morning by actually hearing from Dr. Beth Jonas about the VIRL initiative, as well as Dr. Anisha Dua.
Good morning. Thanks, Jason. Welcome to the final lecture in the Virtual Rheumatology Learning Collaborative series. I'm Beth Jonas, Chair of the ACR Committee on Training and Workforce. Before we get started this morning, I wanted to just share some thoughts with you. First of all, Dr. Dua is on the line, and I want to thank Dr. Dua, who is the program director at Northwestern, really for creating the concept and framework for this series and recruiting an amazing group of faculty from training programs all around the country who've come together to share their knowledge and expertise. Thanks also goes to all the faculty, both the lecturers and those that work behind the scenes to organize and moderate the sessions. There are too many of you for me to name individually, but you know who you are. The fellows also stepped up in a really big way to be co-moderators and to develop summaries of the lectures that are now posted on the energy of this group, and I'm so confident in the future of our specialty. A big thanks also goes to the ACR staff who did not miss a beat when we brought the idea of hosting this series to them. A special thank you to Connie Herndon, who kept us all on track, and to Ngozi Afulezi, who was our online host for the lecture series. We look forward to continuing this collaboration to bring you additional online learning activities in the near future, so stay tuned. Thank you also to all the learners who logged in or viewed the series on the ACR website. As of today, we have almost 2,000 learners from 50 countries around the world to have signed up for this series, with an average viewer size of about 450 on each live lecture. I think we were really all blown away by those numbers. Your feedback has been amazing and welcome, and if you've not had a chance to submit your feedback on each of the sessions, I would please encourage you to do so. In addition, US fellows and program directors should have received an additional short survey last week. Please fill this out. It should only take you a minute or two, and send it back. We are looking for that information to guide our development of future learning activities. Finally, I just want to also say thanks to you all for being here, for being with us at this final lecture. I hope that you are all safe and healthy. I know this has been a very challenging time for everybody. We've learned a lot. So we're going to try to stay up on these things and bring you more activities in this format. So stay tuned for more. So Anisha, if you have anything you'd like to say, I'd like to turn it over to you.
Oh, thanks, Beth. No, I just really wanted to echo what Beth was saying. This couldn't have happened without the collaboration of so many people within the ACR, the moderators, the fellows, the lecturers, Beth, and all of you guys who are logged in and participating and asking great questions. This has been amazing. It's one of the seriously few very positive things that have come out of this crisis. So thank you all. And then you may, I know the US program directors and fellows will be getting a specific survey to help us guide future learning, but so will the rest of you likely in the next few weeks. So if you do get emails from us, please open them and fill out the surveys. We're trying to keep them as brief as possible, but they really are important in terms of future development of initiatives like this. So thank you all. This has been amazing. That's it for me, and Jason will go from there.
All right, well, I think we'll get started this morning then. Just a little bit of housekeeping items that we usually go through. There is a chat button at the bottom of your screen that is used to make general comments. There's a raise your hand button if you're having any technical issues, and then the Q&A section is really where you should put any kind of questions that you have for Dr. Rosenbaum, and then myself and my co-moderator, Marco Lopez Velasquez, will kind of collate them, and then we'll present them to Dr. Rosenbaum at the end of his lecture. To introduce Dr. Rosenbaum, so James Rosenbaum is the chair of arthritis and rheumatic disease at Oregon Health and Science University, where he holds an endowed professorship in his father's name. Dr. Rosenbaum is the only having received training in both of those specialties. He's the author of over 600 scientific papers and book chapters, mostly in the area of inflammatory eye disease. And we're looking forward to your lecture this morning, Dr. Rosenbaum.
Thank you very much. I am honored to be a part of this innovative series, and it's a delight. This was my first content slide, and this is a pretty complete list of rheumatologic diseases that also affect the eye. And I was making the point that even fibromyalgia changes the nerves in the cornea and actually has an ocular manifestation. So my agenda today is to try to make this practical. I'm going to share 4 cases, very brief cases: red eye in a patient with RA, red eye for a patient in the emergency room, blurry vision in lupus, and then double vision with proptosis. So here's the eye. As I said earlier, it's about 2.5 centimeters from the cornea to the back, the optic nerve. It has 3 layers. The outer layer is the sclera, which is the white tunic that goes all the way to the back, and it gives way to the cornea, which is a window. The cornea is really modified skin. The middle layer is the uvea. That's the Greek word for grape. I'm sorry, the Latin word for grape, I believe. And it is the middle of the eye. It's the iris. It's the ciliary body where the aqueous humor is actually synthesized. And the inner part of the eye is the retina and the optic nerve, which many people consider to be an extension of the brain. The vitreous humor is the largest space-occupying area in the eye. It has hyaluronic acid and type 2 collagen, so it's like a joint. And the anterior chamber has aqueous humor. It has almost no cell, should have no cell if it's normal, and very little protein. So let's start with rheumatoid arthritis. 35-year-old woman has seropositive RA, and she's being treated appropriately with methotrexate and the TNF inhibitor. She comes to your office and she says, "My eyes are red." So what's the differential diagnosis for red eyes in general and for rheumatoid arthritis in particular? What should you ask this patient? And can you help this patient, or do you need an ophthalmologist? So here's a picture of a patient with an obvious red eye, and there's a differential for a red eye. The most common cause would be some form of conjunctivitis, and then conjunctivitis itself has many different causes. It could be chemical, it could be allergic, it could be viral, it could be because the eye is dry, and that's obviously the most common reason why a patient with rheumatoid arthritis would have a red eye. The cornea can be inflamed, as in a contact lens wearer who gets a bacterial ulcer. An anterior uveitis that starts suddenly causes a red eye. Episcleritis and scleritis are entities that I'm going to discuss a little later. If the acute closed-angle glaucoma, the eye becomes red. If there's a subconjunctival hemorrhage, which is a benign condition, you'll see redness focally in the eye. And then if there's a lid problem, especially at the lash, that's blepharitis. It's really common, especially as you get a little bit older. So as a rheumatologist, I think you should remember the same mnemonic that I teach to my patients. And the mnemonic is RSVP. Has the redness been present for several weeks? Are you sensitive to light? Is your vision affected, or do you have pain? Any of those 4, persistent redness, sensitivity to light, vision change, or pain, should prompt a patient really to be seen by someone who can use a slit lamp, basically an ophthalmologist or possibly an optometrist. And then in addition to RSVP, you probably want to ask the patient, what treatments are you trying, and if you have a discharge that might suggest a bacterial infection. So overwhelmingly in RA, the most common cause of eye redness would be a dry eye. But patients with RA are also more likely to develop episcleritis, and about 1% of patients with RA develop scleritis. So I'll tell you specifically about that entity. I'm not going to go into detail about dry eye because I understand you had another lecture already about Sjogren's syndrome, But I do want to share with you some practical things that you can do before you send the patient to the ophthalmologist. First of all, a lot of dryness is due to medication, and there are scads of medicines that cause to mood-changing medicines, to sleep medicines. So sometimes you can't change those medicines, but you definitely want to ask and discuss the trade-off of using those medicines versus dryness. Dryness is a combination of reduced production, but it can also be due in part to evaporation. So if you're in Arizona, you especially want to be sure that your bedroom is humidified. Blinking is your body's natural way to lubricate the surface of the eye. If you're giving a lecture, if you're driving a car, if you're staring at a computer screen, if you're reading a book, you are going to blink less frequently. So remind your patients to blink. Tear film replacement is important. A lot of a lot of artificial tears have a preservative. And that preservative, if it's used frequently, like say 3 times a day or more, is toxic to the cornea. So we usually say that you should be using preservative-free artificial tears, which means that you dispose of the tear at the end of the day. Sometimes we recommend that you go to the blood bank and you have sterile autologous serum prepared, because that's even more viscous, more soothing, and it has growth factors that can help the cornea repair itself if it's being damaged from dryness. And then there are 2 FDA-approved drops that can be used for tears or to increase tear production. One is topical cyclosporin, the other is topical lifitegrast that inhibits the binding of LFA1 to ICAM1. Neither one is very effective, and yet I think there's about $1 billion of topical cyclosporin sold in the United States every year, which just speaks to how impoverished our therapeutic armamentarium is. Punctal occlusion and scleral contact lenses are gambits that maybe the ophthalmologist might try. So this is not dry eye. This is not conjunctivitis. This is an example of scleritis, where the eye is usually tender. Sometimes it has a nodular appearance. And scleritis is a very rare disease, but it definitely increases in patients with rheumatoid arthritis, especially in patients with rheumatoid arthritis whose disease is poorly controlled. Another complication of rheumatoid arthritis is scleromalacia perforans, where you develop a nodule in the sclera. And if you were to biopsy that nodule, it would look like a rheumatoid nodule, whether you're biopsying it from the elbow or any other part of the body. I used to see a fair amount of scleromalacia perforans when I was a This is a vanishing condition. I don't think I've seen a patient with scleromalacia for years. But here are the kinds of changes in the rheumatoid arthritis patients where you might be seeing scleritis or scleromalacia, a peripheral vasculitis, a small vessel vasculitis that is often prominent over the malleoli, or someone who has abundant nodules. Now, when I started doing eye disease, rheumatoid arthritis was overwhelmingly the most common systemic disease associated with scleritis. About 40 to 50% of patients with scleritis do have a systemic disease. But I think that as RA is better treated and we see scleritis less commonly in association with RA, vasculitis, especially ANCA-associated vasculitis, is replacing rheumatoid arthritis as the most common systemic disease. And I'm going to elaborate on that in just a moment. Patients with either Crohn's or ulcerative colitis can get scleritis, polychondritis, arthritis and ankylosing spondylitis can also cause scleritis, Behçet scan, and there are infections like herpes zoster or after ophthalmic surgery where you might see scleritis as well. The infections are rare, but because we usually treat these patients with immunosuppression, the infections become extremely important to not overlook. And the ophthalmologist is usually the one who should be identifying the infection. So a more common cause of focal redness in the eye is episcleritis. Episcleritis is increased in rheumatoid arthritis, but it's common in patients just without a systemic disease, and it's a benign condition, whereas I said scleritis is not a benign condition. Scleritis is usually extremely painful. Episcleritis is an irritation. The average duration of scleritis is 7 years, whereas episcleritis usually lasts a few weeks. Scleritis is associated with complications like cells within the eye, optic nerve edema, glaucoma. Generally, there are no complications with the superficial episcleritis. There's usually no association with systemic disease in episcleritis, but it could be part of polychondritis or RA or IBD. Scleritis is often associated with systemic disease, about 40 to 50%, as I said. When an ophthalmologist examines the eye, the ophthalmologist usually uses a drop of topical phenylephrine to dilate the eye. But the phenylephrine is a vasoconstrictor. It will blanch the episcleral or conjunctival vessels, which are superficial, but the scleral vessels are too deep to be blanched by phenylephrine. So the ophthalmologist has an advantage in being able to diagnose scleritis by using that drop of phenylephrine. And the deeper vessels have a bluish or violaceous tinge. The superficial vessels, which would be episcleral or conjunctival, are usually light pink. Now, I mentioned the importance of ANCA in evaluating a patient with scleritis. So some of you will be seeing referrals from an ophthalmologist. Patient has scleritis. Could you tell me if the patient has a systemic illness? Over a decade ago, we looked at 101 consecutive patients with scleritis evaluated in my clinic, and we found that 14% had a positive ANCA, half were P ANCAs, half were C ANCAs. But our conclusion was that those patients who had a positive ANCA usually had a very limited form of granulomatosis with polyangiopathy. Required more aggressive immunosuppression. So if you are getting these referrals, you take a thorough history, and that will help you diagnose inflammatory bowel disease, polychondritis, ankylosing spondylitis, psoriatic disease, RA, or GPA. I do think that an ANCA is informative, and the scleritis is often the first manifestation of ANCA-associated disease. So even if the patient denies sinusitis, has no lung symptoms, I do obtain an ANCA, and I like it to do a SED rate as a screening for a systemic illness. Now, the general treatment for scleritis is immunosuppression. And that's because about 80% of patients with scleritis presumably have a systemic vasculitis, even if it's not apparent. But about 20% of patients with scleritis will respond to an oral nonsteroidal like ibuprofen, indomethacin, naproxen. And we don't usually biopsy the sclera because that might cause a perforation of the eye. But my hypothesis is that some patients with scleritis have something akin to an enthesopathy. Those are the patients with ankylosing spondylitis, some of the patients with IBD, but again, most have a vasculitis. So I'll try a nonsteroidal, and I'll usually know within a day or two if the patient's going to respond. If they don't respond, I stop the nonsteroidal and I switch to oral corticosteroids, often prednisone, sometimes at a dose as high as 60 milligrams per day. Because the average duration of scleritis tends to be lengthy, I said 7 years earlier, I switch or add an immunosuppressive like azathioprine or methotrexate, usually early on. Some of my colleagues like to treat with periocular corticosteroids. I don't, because the periocular steroids will enhance thinning. And then if the patient has an underlying disease like inflammatory bowel disease, rheumatoid arthritis, or GPA, the biologic that treats the underlying disease will also treat the scleritis. In a continuum with scleritis in RA is a rare complication where the peripheral cornea becomes thin and it can perforate. The patient will think that they're tearing because the aqueous humor will pour out, and the eye could actually be totally lost from this complication. The name of this complication is a corneal melt. A synonym for that is PUK, peripheral ulcerative keratitis, or marginal keratolysis. And when you see this, or when an ophthalmologist refers a patient like this, it's almost always due to a systemic vasculitis. But be careful, there are traps. Occasionally a viral keratitis, as could be caused by herpes simplex, could do this. Occasionally there's a disease called Morin's ulcer, which looks like this, but it's not associated with a systemic disease, but still might require systemic immunosuppression for treatment. Okay, I'm going to head on to case 2. The emergency room doctor pages you in the middle of the night because there's a 35-year-old male who's got a unilateral red eye. This is a photo that I showed you earlier. The emergency room doctor knows how to use the slit lamp, and he says that this patient has an anterior uveitis, and because it started suddenly, it's AAU, acute anterior uveitis. He thinks that this patient has a rheumatic disease. You want to tell him to go back, that you need to go back to sleep, but is that emergency room doctor astute, or is he just annoying you? And the answer is that the emergency room doctor is astute because this patient, whose pupil here is smaller than this pupil, must have acute anterior uveitis to affect the pupil size, and this patient has a 50% chance of being HLA-B27 positive, and if HLA-B27 positive, about an 80% chance of having a spondyloarthropathy. So the emergency room doctor performed a slit lamp exam, which is just a biomicroscope designed to examine the eye. When the slit lamp is properly focused, you see the beam of light as it strikes the cornea. You see the beam of light as it goes through the lens, which is proteinaceous. But the anterior chamber here is like a vacuum. The normal anterior chamber has 0 white cells, very low protein. Nothing impedes that beam of light. And so you don't see the beam of light going through the anterior chamber. There's a blood aqueous barrier, just as there's a blood synovial barrier. If you disrupt that blood aqueous barrier, suddenly serum proteins leak into the front of the eye, and those proteins diffract that beam of light so you can see it. So the ophthalmologist gets to see increased vascular permeability in this form of this gray haziness. The 2 universal hallmarks of inflammation anywhere in the body, including the joint, the lung, the brain, would be a leukocytic infiltrate and increased vascular permeability. And an ophthalmologist gets to see that non-invasively and continuously. It's pretty neat to be able to see inflammation. So the emergency room doctor diagnosed uveitis. Uveitis is a topic unto itself. But I put here the systemic diseases that are associated with uveitis. There's some rare systemic diseases that could also be arguably included, but this is the more common ones. And they certainly include ankylosing spondylitis, reactive arthritis, psoriatic arthritis, inflammatory bowel disease, the spondyloarthropathies. They include sarcoid, rarely lupus, rare genetic diseases like the one we used to call Blau syndrome, familial granulomatous synovitis with uveitis, JIA. So and some of the diseases in black, and the ones in black don't generally cause arthritis, but every one of those in red is a potential cause of both arthritis and uveitis. There really are kindred spirits, the joint and the eye. So I argued that that patient in the ER might have spondyloarthropathy. I'm going to show you one slide with data. And this was published in Ophthalmology a couple years back. It's a Spanish study. It's a collaboration between rheumatologists and ophthalmologists, and they called their study Sentinel. They recruited 800 patients who had anterior uveitis. And the first thing they said to their patient was, do you have known spondyloarthritis? And if they said yes, they were excluded. So only patients with anterior uveitis and no known history of spondyloarthropathy were included. I've spoken to the authors a couple of times and asked them if they knew how many were excluded, and they unfortunately don't. But 800 patients, of those with anterior uveitis, over half were HLA-B27 positive. That still left 323 B27 negative. Of those who were B27 positive, they concluded that 71% had axial spondyloarthropathy and 21.9% had peripheral axial spondyloarthropathy. Now, you can't add those two numbers because some patients had both. And again, the authors unfortunately couldn't tell me how many patients had both, but it's fair to say that roughly 80%, I think, had B27 related spondyloarthropathy. And even among those who were B27 negative, they thought nearly 20% had axial disease and 11% had peripheral disease. There is a study out of Dublin, Ireland, specifically about the emergency room. They looked at 100 consecutive patients with acute anterior uveitis in the Dublin ER, and they concluded about 40% of those had spondyloarthropathy. So the ER doctor was pretty astute. By far the most common systemic disease that I encounter associated with uveitis is spondyloarthropathy. Let's move on to case 3, and we're making good time, so I think I'll have time for questions despite the problems we had with the beginning. 35-year-old female, she has known SLE, and she says, you know, doc, my vision's just not as clear as I'd like it to be. I haven't seen a sudden change, but things are just not quite in focus. So what could be doing that? Well, just as in RA, the most common eye disease associated with lupus overwhelmingly is dry eye, and that is probably the cause. And now that you're an expert with preservative-free artificial tears and humidifying the room and avoiding drying medications, you can probably steer her in the right direction without the need to refer to an ophthalmologist, but you now know about RSVP, which would be the reminders that would say, oh, I better get you into an ophthalmologist. Lupus can also cause cotton wool spots. I'll say a bit about that in a moment. Sometimes it's not the lupus, it's the drug we prescribe, the drug that the president has placed in the news, hydroxychloroquine. Rarely patients with lupus get an optic neuropathy. That would generally be a sudden, usually unilateral, severe change in vision. Patients with lupus occasionally get scleritis, and uveitis occurs in lupus, but it's quite rare. So here's a picture of the back of the eye, a fundus photograph. This is a retinal hemorrhage, and this is a cotton wool spot indicative of focal ischemia. Here's the same vessel with what's called a fluorescein angiogram. Fluorescein's a dye that we inject into the antecubital, and then we take pictures of the back of the eye because the vessels are nicely outlined by the fluorescein that binds to albumin. And what you see is right where the cotton wool occlusion, and that sort of occlusion would suggest that the patient has antiphospholipid antibody disease. Not always, but it is common with that occlusive vasculopathy. Here's the hemorrhage. You see it's the same shape, and you don't see very well behind the hemorrhage, so it's blocking. And then this vessel here is dilated, and the dye is staining the vessel wall, so there's a vasculitis in this patient as well. So here's a patient with severe antiphospholipid antibody disease. You see vessels that are occluded, and then they reconstitute. Here you see some occlusion of the vessel. Here's a silvered vessel from occlusion. And then there's some small hemorrhages that are scattered around the eye. And those hemorrhages result from the occlusive vasculopathy, and they're indicative of a retinal vasculitis. But again, this is not a vasculitis that's causing inflammation in the vessels. Diagnosis. Retinal vasculitis is one of my favorite topics, and time precludes me from going into it in detail, but if you are referred a patient with an occlusive vasculopathy, always look for a thrombotic diathesis like antiphospholipid antibodies. So a group in Toronto published this paper more than 30 years ago, at a time when we were still using ophthalmoscopes, believe it or not, in rheumatology clinics. And they had 550 consecutive patients with lupus. And every time a patient with lupus came in, they would dilate the eyes and look with an ophthalmoscope. And they said 7% of those 550 have retinopathy. And by retinopathy, what they usually meant was that the patient had local focal ischemia, which is a cotton wool spot. That presence of retinopathy correlated very well with having small vessel vasculopathy in the brain, CNS disease. They didn't always find the lupus anticoagulant. This was, back in 1988, we weren't doing anticardiolipin antibodies. We weren't doing Russell Viper venom tests. We were looking for the lupus anticoagulant, so they missed some people. But almost 40% with retinopathy, with again, cotton wool spots, had an lupus anticoagulant, and 70% of the controls had a lupus anticoagulant as well without having retinopathy. Back in 1988, this was a bad prognostic sign. So over the 16 years of the study, from 1970 to 1986, a third with retinopathy died. It was 11% of the controls. So here again is lupus with a cotton wool spot, with hemorrhage. But this is a cotton wool spot as well, but it's a cotton wool spot from a patient with lupus that's surrounded by a hemorrhage. And we have an eponym for a white-centered hemorrhage, and that eponym is a Roth spot. So Roth spots are not specific to bacterial endocarditis. They occur in other conditions as well, one of which is systemic lupus. And then this is bullseye maculopathy. This is not due to lupus. This is due to the physician prescribing an antimalarial to treat lupus. This is a late manifestation of antimalarial toxicity. Here's the fovea, the macula, and it's the area around the central macula that's most affected. And so let's say a few words about antimalarial toxicity. These are recommendations from the American Academy of Ophthalmology. It's based on data that were obtained in studying more than 2,000 patients from a Northern California Kaiser database. And these were patients who had serial optical coherence tomography, or OCTs, and visual fields, which are probably the two most sensitive and most important tests in screening patients for plaquenil retinopathy. So the American Academy of Ophthalmology said the maximal dose should be based on real weight, and it should be less than or equal to 5 milligrams per kilogram. They said that you should get a baseline. You don't need to get the baseline before you start, but get that baseline within a couple of months. I usually make sure that the patient can tolerate the plaquenil. We have a T and visual field. There are less commonly available tests, autofluorescence and electroretinography, that are also very good. ERG takes about 4 hours and it's uncomfortable. So I don't use these usually as screening tests, but I do hope that there'll be a baseline OCT. The risk of retinopathy is very small over the first 5 years. And so after you get that baseline, if you're using this recommended dosage, you don't need to send the patient back to the ophthalmologist for 5 years. Although some people like to say, just go once a year because every adult should have an annual ophthalmology exam, and you might as well just get in the habit. But 5 years is the recommendation. So here's what happens over time. This is a visual field, and wherever you see these dark marks, it means the patient is looking at a screen, a light is coming in from the side, and the patient's not able to perceive the light in this area. And here you see over time, the patient's losing this around the central area, around the foveal vision area. That's what happens with progressive maculopathy. You don't see very much if you photograph the back of the eye, but you do see these changes on the OCT. The OCT takes a few seconds. It's highly objective. It's highly reproducible. It is a marvelous test. And the OCT shows you all 9 layers of the retina. It shows you the retinal pigment epithelium. It shows you the choroid, which is this vascular area underneath the arc. And this is a normal macula at baseline, but this is not a normal macula. Here you see some thinning. This is an area called the ellipsoid zone. It's a very faint line, and it's hard to see, but the ellipsoid zone here, corresponding to the visual field change, is beginning to lose or diminish. It's abnormal. And this macular area of thinning, this is sometimes called a sombrero or flying saucer sign as you lose the outer retina from plaque minotoxicity. There's even greater loss here, progressive with time. So OCT is very accurate and sensitive. And if you catch the changes early, they will not progress, they may even diminish, and they won't cause bullseye retinopathy. So there are factors that increase the risk of retinopathy. This is the same reference with the American Academy of Ophthalmology recommendations, where the dose should not exceed 5 milligrams per kilogram. If you're using chloroquine, we have less data, but the recommended dose is not to exceed 2.3 milligrams per kilogram. After 5 years is when damage increases. I'll show you a graph. Increases of toxicity. And if there's pre-existing disease like diabetic retinopathy, macular degeneration, we don't think it makes it worse or more likely to occur, but there may be changes that may confuse whether or not the changes are due to the anti-malarial. So this is a graph based on that Northern California database, where if you stayed at the lowest dose, over time, very little toxicity, even at 10 years of dosage, although out to 20, 25 years, you do get into maybe 1 out of 20 having some toxicity. When you start to exceed 5 milligrams per kilogram of real weight, the toxicity increases so that at 20 years, it may be up to as much as 40%. So you want to be really cautious, and I do subscribe to the idea that the dosage should be 5 milligrams per kilogram or less per day. Now, cardiac toxicity from hydroxychloroquine has also been in the news, and this is a position paper that was from the American College of Cardiology and published in the Journal of the American College of Cardiology about 1 week ago. And they looked at patients reporting torsade or cardiac arrest if you were taking chloroquine or hydroxychloroquine. Now, these are adverse woefully underestimates, but you can see that even with those underestimates, they had had over 200 reports of patients with hydroxychloroquine having torsade or VTAC or VFib, and over 100 cardiac arrests reported. And then if you add another drug that by itself prolongs the QT interval, the numbers go way up. So it's an additional risk factor. And you can see that there were over 250 patients who had cardiac arrest taking the combination of azithromycin and hydroxychloroquine. Now, there are lots and lots of drugs that prolong the QT in addition to antimalarials. So I took this from the US Pharmacist website, but now with my electronic record, if I prescribe an antimalarial and the patient's also on something independently prolonging the QT, I get a warning. And I think you definitely want to be doing EKGs on those patients and making sure that the QT interval is normal. So I'm almost out of time, but I was told I get a few extra minutes because of the introduction and because of the technical problem. So I'm going to tell you about a fourth case, a 35-year-old male who's got unilateral proptosis and diplopia, and the ophthalmologist wants to know if this patient has a systemic disease. So rheumatologists in general are not very familiar with the differential diagnosis of orbital inflammation, which would cause proptosis. We did do a review of this in seminars in 2008. Joe Lutt was my But there's a differential diagnosis for proptosis, for a mass in the orbit that you could see on CT or MRI imaging. The most common cause is thyroid eye disease. And exactly why patients with Graves' ophthalmopathy get this, it's unclear. But for a rheumatologist, the most important disease to remember is GPA. That's a very rare cause, but it's a definite known cause of orbitopathy. Sarcoid could cause a mass in the orbit. A lot of patients with orbital disease have NSOI, which we used to call pseudotumor, nonspecific orbital inflammation. IgG4 disease could cause it as well. But be careful, because lymphomas and metastases can get in the orbit, and there are infections where you definitely don't want to be using immunosuppression. So you need to be working with an ophthalmologist, often an oculoplastic surgeon. Within the orbit, there are different tissues that get inflamed. It could be an orbital myositis. It could be the adipose tissue in the orbit. It could be the lacrimal gland, which we would label a dacryoadenitis, or some combination of those three. Here's an old NIH series on GPA, and just to show you that 40% of patients with GPA get ocular involvement. Here's the initial, here's the total. Scleritis is the most typical. Lacrimal gland involvement is common, and orbital disease is certainly a known complication or association with GPA. I'm going to skip pseudotumor because of the time, but I do want to tell you about thyroid eye disease, which, as I said, is the most common non-infectious cause of orbital inflammation, and it has special treatment recommendations. So for GPA, for nonspecific orbital inflammation, or for sarcoid, I treat with immunosuppression. But thyroid eye disease responds very begrudgingly to immunosuppression. You may start getting referrals to treat thyroid eye disease, and that's because we now have an approved monoclonal antibody that works extremely well for thyroid eye disease, and most ophthalmologists are not comfortable prescribing a monoclonal antibody. The greatest environmental risk factor to get thyroid eye disease is smoking, and if you stop smoking, often the proptosis will get better. Oral corticosteroids work transiently. They're not a good long-term fix, but most ophthalmologists will try oral corticosteroids. IV corticosteroids work better. I'll show you a regimen in just a moment. Steroid-sparing immunosuppression for thyroid disease has a limited role, like methotrexate. If the optic nerve is being compressed, the patient may well need decompressive surgery. There might be a small role for radiation and a small role for tocilizumab. So in Europe, there is a group called the European Group on Graves' Ophthalmology, Graves' orbitopathy, sorry. And they issued guidelines that are called UGOGO, the European Group on Graves' Orbitopathy Guidelines for Orbitopathy. And the UGOGO recommendations are to use myofortic, mycophenolate at a low dose, 360 milligrams BID. I use mycophenolate mofetil, 500 BID, and to give IV methylprednisolone, which again works better than oral. You do the methylprednisolone IV weekly for 6 weeks at 500, then 6 weeks at 250, and there's a 71% response rate if the patient takes the combination of this low-dose mycophenolate and IV steroids. This is a slide showing that tocilizumab is an option as well. But what I really want to show you is that teprotumumab is the now golden child for treating this disease. Teprotumumab is a monoclonal antibody to the insulin-like growth factor 1 receptor. And although we see Graves' orbitopathy in association with a typical autoimmune disease, that is Graves' thyroidopathy, it's not so clear that the orbitopathy is inflammation, but there is activation of the IGF-1 pathway. There's an expansion of orbital fat, and this drug, teprotumumab, works incredibly well. It works about 85% of the time. This was published in the New England Journal using what's called the clinical activity score. There was a second randomized controlled trial, which was based solely on reducing proptosis, at least 2 millimeters. And 85% of patients had at least a 2 millimeter reduction in proptosis, as opposed to 14% of the controls. So 85 versus 14, that's a very impressive monoclonal antibody. The problem here is not how effective this is or how safe it is. It is relatively safe. It doesn't cause immunosuppression. The problem is the expense. And the expense right now is $200,000 for a 24-week course, giving it intravenously every 3 weeks. So how do I approach orbital disease? I collaborate with an oculoplastic surgeon. We use imaging and sometimes biopsy to rule out infection and malignancy. We treat thyroid eye disease differently, but nonspecific orbital inflammation, sarcoid, ANCA-associated vasculitis, I do treat with oral corticosteroids and immunosuppression. For thyroid eye disease, I like that UGOGO regimen, and teprotumumab is an option. And for other inflammations, as I said, methotrexate and a metabolite, rituximab. So I have tried to make you mini ophthalmologists in 50 minutes with technical problems. I doubt that I've quite succeeded with that lofty goal, but remember that virtually every rheumatic disease can affect the eye, and if you understand ocular inflammation, you will, I guarantee, be a better rheumatologist. So thank you for your attention. Thank you for participating. I'd be glad to try to field some questions.
Thank you, Dr. Rosenbaum, for that excellent lecture. And thank you for all our attendees for all the questions that you posted. We're going to try and go over as many as we can. First question is on the subject of treatment for ANCA-positive scleritis. In patients that do not have any evidence of systemic disease, how long do you normally treat with steroids? And if you have to consider another, agent, what's your preferred agent of choice?
So in that setting, I almost always need an immunosuppressive. And so I usually, if someone's ANCA positive with scleritis, even if there are no other manifestations of ANCA-associated disease, I will usually use methotrexate along with prednisone. And I'll taper the prednisone over 8 to 12 weeks so that hopefully the patient's completely off. I use methotrexate along with folic acid. I prefer to give the methotrexate by injection. I usually use a dose of 20 milligrams per week if the patient can tolerate that, and if the liver function tests are normal. That dosage is based on data published by a fellow named Sneller when he did a trial when he was at the NIH using methotrexate for limited ANCA-associated disease. And I think the response rate is fantastic. If the patient doesn't tolerate that or the response is incomplete, I will often try azathioprine or I will advance to rituximab. If the patient has sinus disease, I will use a drug like Bactrim along with the methotrexate to reduce the likelihood of PCP. And I think there's some evidence too that Bactrim by itself may treat underlying ANCA-associated.
To the next question, and this is on the subject of Plaquenil toxicity, eye toxicity. Is there any preference on performing an OCT over an ERG? Is there a role for doing an ERG or electroretinography first?
Right, so ERG is terrific. It's very sensitive, but it does take hours to perform. You certainly wouldn't find an optometrist who can do it. I think even in my own institution where the Department of Ophthalmology probably has 20 to 25 ophthalmologists, there's one ophthalmologist who can perform an ERG. You put electrodes all over the eyelid. You have to be patient. It's uncomfortable. It takes about 4 hours. It's expensive. I never use an ERG as part of a screening test, though it's interesting and can sometimes help localize or confirm the diagnosis. OCT, on the other hand, takes seconds. It's much less expensive. It's easier to reproduce and redo. So in terms of a screen, OCT is my go-to along with visual fields, and the ERG in a rare, complicated confirmatory test, that's when I turn to ERG.
Jim, there was 2 other questions about kind of Plaquenil and screening. If someone has baseline visual field defects or OCT changes from a different cause, how do you approach Plaquenil screening in those patients?
Right, so a big part of using an antimalarial is communication. And hopefully the rheumatologist is talking to the ophthalmologist and the ophthalmologist is talking to the rheumatologist. And when I lecture to ophthalmologists, they complain that the rheumatologist doesn't speak with them. When I lecture to the rheumatology group always complain that the ophthalmologists don't communicate. So if you talk back and forth, it really helps. But you know, if a patient has macular degeneration or diabetic retinopathy, those would be the 2 most common retinal diseases. They may well have pre-existing visual field defects. And those don't absolutely preclude the use of an antimalarial, but it does make it more complicated to determine whether the further changes are due to the drug or due to the underlying disease. So you just have to weigh the risk-benefit ratio, and you have to be able to talk to the ophthalmologist to see how comfortable the ophthalmologist is in allowing, you know, continued usage of the drug.
Okay, great. Along the lines, because you know renal insufficiency is associated with retinopathy, do you have an approach for dosing Plaquenil in renal insufficiency, or do you avoid it in that setting?
Right. So, you know, we don't have good data. Some people are relying on hydroxychloroquine blood levels. Know enough about blood levels yet to correlate the blood levels with toxicity and efficacy, but there's some correlation. In general, assuming that say the creatinine is 2, that the GFR is 40-ish, I would probably use half a dose, and I might be getting the OCT in the visual field every 6 months instead of every 12 months. But it doesn't preclude the usage. I would just cut down the dosage and be a little more diligent in the follow-up and the screening and the testing.
Excellent. And we're going to move to other questions in regards to treatment of uveitis. We know that Humira is approved for treatment of uveitis? Any other biologics that you would recommend? And in that, also in that same topic, any risk factors for patients with ankylosing spondylitis developing uveitis?
Right. So those are excellent questions. So Humira is the only biologic that is approved for uveitis. In fact, it's the only non-corticosteroid that is approved for uveitis specifically. And that's because there were 2 well-designed randomized controlled trials. It is not FDA approved for the patient I presented. I presented a patient with an anterior uveitis, and anterior uveitis is almost always responsive to topical corticosteroid. Humira is approved, or adalimumab, I should say, is approved for non-infectious intermediate, posterior, or pan-uveitis. Those are diseases where if you put a drop on the front of the eye, it doesn't swim to the back very effectively. So those are the diseases that are more likely to need an immunosuppressive therapy. No other biologics are approved. There are anecdotal reports of efficacy of things like rituximab or anti-IL-6 receptor. So those are occasionally used. But Humira actually works extremely well. It's not the first drug to turn to if you need to immunosuppress a patient with non-infectious intermediate posterior pan. I like methotrexate at about 20 milligrams per week. The group from Johns Hopkins, which is terrific, likes mycophenolate. Azathioprine is often effective as well. And then if the patient has severe vision-threatening disease, I would consider adalimumab. And by the way, the one exception would be a child. So a child who has juvenile idiopathic arthritis in association with chronic bilateral anterior uveitis, they should be treated with drops. If drops aren't adequate, we add methotrexate. And if that's not adequate, we add adalimumab, which the FDA has approved. That's the one exception of the anterior uveitis that is okay to use adalimumab, chronic anterior uveitis in a child.
I think we have time for maybe like one or two more questions. Jim, people wanted to know, like, what's your approach to either meibomian gland dysfunction or blepharitis if it's contributing to kind of irritation in our patients with Sjogren's or RA?
Sure. So we call that MGD, meibomian gland disease. With a slit lamp, you'll see little collarettes, you'll see little globlets of fat around the eyelash right at the root. I don't know that you want to get into treating that, but the first pass of treatment is baby shampoo, and you put a little baby shampoo on a Q-tip. And you do that day, and you usually take a warm washcloth and put that on the lids for 10 or 15 minutes once or twice a day. And that's the first part of treatment. If they're not responding, I would probably send the patient to an ophthalmologist.
There's some other questions that are in the queue, but I think we're out of time for now, and they'll be sent to you as well for you to review those.
My pleasure.
All right. Thanks again.
My pleasure. Thank you all for attending, and have a wonderful weekend.